So next in the programme, we have an interview. So well-known journalist and author Yasmin Alibhai-Brown is my co-chair in the Centre for Patient Safety and Service Quality. And Yasmin is going to be interviewing Peter Beresford, who is Director of the Centre for Citizen Participation and chair of Shaping Our Lives, which is a national network of service users and disabled people. And one of the great joys of working in the Centre for Patient Safety is the huge diversity of research groups we have. We've just been hearing about technology and design, and then we've got others within our centre with a real passion for how we involve and engage with a really diverse range of the lay public. And it's on that note that Yasmin's going to be interviewing Peter. So thank you very much, both of you, for this.
Thank you, Bryony, and really good to see so many people here. One of the things that the two lay members, there were two of us who've been involved with the work of CPSSQ and some of the other patient safety work, we've kind of brought other issues into the room, which has been really interesting because we learn a lot, but also, of course, being outsiders, we can bring other questions and experiences to improve the whole way we think about patient safety and so on. So about 2 months ago, I think it was, I organized a small round table meeting of practitioners, researchers, patient relatives, policymakers, a couple of journalists. It was a private meeting where people spoke openly about diversity, patient engagement, patient involvement, and ultimately patient safety. And so that was sort of step one. And this interview has come from what was said during the meeting and some of the case studies. Some quite actually worrying case studies that we heard about how patient safety was compromised because of language difficulties, certain assumptions being made about who the patients were and what they wanted and what they thought. Kind of a little bit of ignorance, perhaps, about the patients that were being dealt with and so on. And because it was a private round table, it was a very honest and good discussion. And one of the results was to invite Peter Beresford to come and talk to us about his thoughts and ideas. I am going to do a very short biography of Peter. He is a professor of social policy at Brunel University and visiting professor at the University of East Anglia and Edge Hill University and in OBE. He's also has experience as a user of mental health services and is co-chair of Shaping Our Lives, the National Disabled Peoples and Service Users Organization network. And he has had a very long and very well-respected involvement in issues of participation as a writer, researcher, educator, and campaigner. His new book is All Our Welfare Towards a Participatory Social Policy. I'm going to let him tell you about his last book. But just to tell you, when I phoned him, he said, "We've met, you know." And I said, "Oh, have we?" "Oh, I don't remember." He said, "Yeah, you told me once on a train to not to talk so loudly on my phone." And I'm glad he has still agreed to come here. It's just what a bad-tempered old bag I can be. I'm so sorry.
No. I felt very guilty. Of course, unfortunately, I realised who it was.
I'm much better now that you've told me. I won't do it again. So let's just start with, I mean, nobody in this room needs to know why this is important, but it would be good from where you're sitting, what you think about the focus and the way we're talking about patient safety, patient involvement, and so on.
Thanks, and it's really nice to be here. Just to say that, as Yasmin said, I'm part of a national service user, that's to say people particularly who are long-term users of health and social care. and Disabled People's Organisation. And it's interesting, so interesting to be here, because we never talk about patient safety. People talk about good things with services and people talk about problems with services, but don't frame them in terms of safety. And that's one of the things we do tend to do, don't we? We abstract issues, disconnect them because we perhaps feel we need to. So this is patient safety. But obviously what patient safety is all about is if things go wrong. And it seemed to me, listening to the earlier contributions, that this is one of those places where what is human and what we try and do together, creating policy and practice, can collide, and we see evidence of where things go wrong when they do collide unhelpfully. But you mentioned, Yasmin, the new book which will be coming out, this isn't meant to be a plug, it's because this is where for the last 2 years a lot of my thoughts have been, and it's a book where I've been trying to make sense of the welfare state that was created, and remember the NHS has always been a jewel in that crown, where we've got to with it and where we might need to go. And the two things that have really come out for me trying to make sense of the origins of the welfare state was that it didn't give much priority to two things. It didn't give much priority to people as service users, as patients, themselves being active participants. It really was cast in the mold of we as good people with expertise will try and do good things to help you. There's a very strong strand of that still, and we know there is in the NHS. The other thing which it didn't really do, and I don't think that the social changes that have come since really are adequate excuse for it failing to do that, was it didn't really think about difference. It didn't really value diversity. The people, and it was mostly white middle-class blokes, the people who set it all up did not have a notion of questioning the way that people were cast, the way that people were cast in terms of gender, ethnicity, age, sexual, the rest of it. So it was all stuck there. And I think what we've seen over the years is serious attempts in all services, including the NHS, to grasp that. And this issue we've got today that we're going to talk about is about those two key things. It's about involvement, challenging that historical inheritance, but not just, as it were, and we called a project that we carried out that, not just including the usual suspects. Because I have to say, you've used the word once. This word lay drives me balmy.
I'm sorry.
No, I hate the word lay. And when they talk about involving people and they talk about lay involvement, often what you've seen is that it'll be something like an important committee and the lay person is some superannuated professor like me who no longer is the professor, but now we can drag him on, or he's determined to be dragged on, to be there cast in the role of lay. Lay doesn't mean or shouldn't mean that. Lay must mean all of us and all our experiences.
Yes, because we are all one way or another patients as well as whatever else we do. Now, in the usual suspects and your other research project, the Developing Diversity Project, you list quite a number of constituents, if you like, who are not the usual suspects. And I found that list very interesting because I looked at what you were talking about here. Like gender, you've said ethnicity, culture, belief systems, sexuality, age, disability and class, older people, homeless people. I mean, I've never heard that mentioned before. I've just walked in Leicester Square and found a whole bunch of homeless people outside a theatre who, honestly, the smell, because they'd just not been able to wash. So how totally excluded they are from our society. People living in residential services, in prison. Some politicians may not like that. Travellers and gypsies. People whose rights are restricted and denied, who don't have citizenship rights, refugees and so on. So actually you're looking at millions of people here, aren't you?
We are. I mean, people will know that, I suppose really since the 90s especially, but even more recently, there's been a real push in public services, especially I think NHS and social care, for people to have some real say and involvement as members of the public, as patients. So we've had the last Secretary of State, or the one before, telling us that you know, we should have a say in decisions that affect us. And that's great. It just does depend on who we mean by we. And we carried out this study, and it was funded by the Department of Health. And we, when I say we, all of us who were involved in this study, those running it, those carrying it out, and those we spoke with were people who were people with long-term experience of using health and social care services as mental health service users, including people with learning difficulties, older people, disabled people, people with learning difficulties, people with alcohol and drug problems, and so on, and others long-term conditions. And we wanted to find out if it was the case, as we suspected, that some people didn't get involved when people were meant to be getting involved, who they were and how we might be able to challenge it, why that was. Because there's been talk of what's called hard-to-reach people and seldom-heard voices. And as someone said in that project, it's not about hard-to-reach or seldom-heard people, it's people that they don't want to listen to or don't make efforts to listen to. But the thing that struck us at the beginning of this project was that if you had something set up to make it possible for people who didn't usually get heard to be heard beyond the ordinary processes of democracy, of, you know, voting in elections and the rest of it, and they still weren't, then all you were doing was reinforcing all the exclusions and discriminations that exist and operate anyway. So it was especially important, if you want the whole picture, to inform public services and policies like the NHS to get all those voices. And it's, as Yasmin said, we found 5 major categories, as we identified them, of people who routinely tend to get excluded. First, as you've said, Yasmin, you've summed it up rather, but I'll try and pull it out a bit more, on the basis of the usual issues of equality around age, gender, sexuality, race, age, disability, class, culture, and the rest of it, but also according to where you live. If you're homeless, if you live in an institution, if you're in prison, if you're in residential services, if you're a traveller, a gypsy. And then if you have particular communication issues, and I noticed in the last presentation there was sensible discussion of communication, which we tend to neglect. But many people communicate in ways which may mean that you have to pay special attention to them if they're to be truly included. If they are deaf, if they are blind and deaf, if they don't communicate verbally, if they have learning difficulties, and of course people for whom English is not their first language. And we also found that on the basis of some impairments, people tend to get left over, glossed over. If it's felt that the impairment is rather a big one or a complicated one, then people raise issues like, do they really want to get involved? Could they be involved? Or if it's an impairment that's seen as difficult, like perhaps someone who has dementia, someone who's seen as being on the autistic spectrum, then there's a high risk that you will not be part of whose views are asked. And then another group we found were people who were kind of unwanted voices. That's to say, people who it might be felt we don't necessarily want to hear what they've got to say because they might rock the boat. They're not coming at this from the same place as us. Can we really cope with their disagreement?
So that's what I was going to ask you. One of the reasons, why does this happen? I remember once, many years ago, I had an asthma attack and I passed out on the street and I was taken into hospital by the ambulance. And as I was recovering, they were talking about me. And they were talking about me as if I most obviously didn't speak English. Now, the reason they were doing this is I was wearing Indian clothes that night because I'd been to a function. And so they were talking about me as I was recovering, and it was really strange to be that they'd made this assumption. They had not said anything. And they were talking about me. I mean, she probably doesn't speak any English. You know, how will we communicate with her? Probably didn't take her inhaler. You know, does she even... I mean, it's just quite... It's like a play. It was like a kind of one-act play. Why does it happen, in your view? Is it because we're all like that as human beings? We stay within our comfort zones, especially when we're busy and trying to do the right thing, but, you know, we don't have time for all this complication. Is it that we are all, again, we all have repetitive behaviors? We think of patients as partners. We consult a group of patients because those are the patients we've been consulting before, or they're replicas or whatever. Is it the context? Is it, once upon a time, diversity was very high on the agenda in terms of service delivery across the country in education? that it's kind of been edged out? Or is it self-exclusion? People don't want to be talked to for whatever reason.
I think it's all those things. I mean, you've given such a list, and I think a very sensible and convincing list. I think there are social, and I think there are professional, I think there are psychological issues. I think that more and more we seem to be socialised in ways which limit who we get to know, who we feel comfortable with, the people you were talking about. I think that's been happening very much with the kind of social revolutions that have been taking place in recent years in terms of increasing inequalities, increasing separations between those who are rich, those who are poor. The way that we're beginning in some ways to follow in a kind of an American example in the way that where we live, where we go to school, may be very separate from people who would be seen as different from us. And it's still the case, and we've seen this with our daughters, that you go to school and you meet very few children as peers with impairments, because they're still probably somewhere else. And that doesn't really provide a helpful start. And I think that there are really big issues here for training and learning for every person involved in NHS and social care to familiarise themselves with people who are different. And one of the really good things that's developed, especially in social care and social work, but also increasing in the NHS over the last number of years, has been using people with these experience in their diversity as educators, as trainers, to bring them in. I mean, some courses bring in actors to be service users, as if we have a problem and there's a shortage of patients. And why behave as an actor as you think patients behave when you can hear from the horse's mouth? So we need to do all these things. But I want to come back to the point you raised about, do we cut ourselves off? Because I think we do, because I think people often in a situation of need, especially if they've had additional exclusions and discriminations, are very wary of getting involved. They'll think that they'll make a fool of themselves, they'll be asked things that they don't understand, that people will judge them, and sometimes people are frightened that if they are critical of a service, that then that service might be withdrawn from them, or they might get retaliated because they haven't said the right thing. So I think, I guess for everything, it's been part of my whole way of working. What we must try and do, and you sort of say it when you talk about your personal experience, is we've got to challenge the way that we as workers, as professionals, can be separated from us as people who are living human beings. You know, there's talk in social care especially of working with vulnerable people. And I remember a really good policy person saying once, you mean that we're invulnerable? And of course, any of us can have really nasty things that bring us to the attention of the NHS, and doubtless some of us are now, happen to us as professionals too. So it's to try and reunite ourselves, and that's, I think, what really works well for everybody.
And just to end on a good note, have you seen projects or experimental work going on where people have worked out how to do this better?
Absolutely. I mean, ours was not just a research project, it was also a development project, and you can download the resources from Shaping Our Lives website, so that we actually were able to give some resources to local organisations to do some things, to find out more and to challenge. And what we really found out very briefly was that if we want to involve people, we've got to move away from things like questionnaires, surveys, public meetings, writing and reading, and those sorts of things, and have much more innovative, enjoyable, culturally appropriate, outreaching ways of engaging with people. And people, if they have a sense that being involved is for real, it's not just a rubber stamp or tokenism or to just strengthen a decision already pretty much made. If they feel that they can have a real voice in things, will want to take part. And the other thing to say is I think good practice, good professionalism at every level, from the receptionist onwards through to the most important consultant, is about being participatory in how you work with service users and patients. Always taking your cue from them, always asking them, trying to be guided by what they want, and if a time comes when they can't say, trying to remember what they were saying when you could see them as a fuller person earlier on.
Are we not doing questions? We do have time? Yeah. 2 or 3 questions would be great.
Do we have comments or questions for Peter or indeed for Yasmin? There's one at the back here, if you could, sort of in the middle towards the back row. Raoul, you're getting there with the microphone. Perhaps I could ask you a short one. Peter, if there was one thing you would like me and many of my colleagues to take away as a researcher in patient safety to address some of the issues that you raise, what would that be? What would you like me to do differently?
Well, as a
from
researcher,
today?
I'd want to say to you that there's now a growing body of exploration, of thinking, of theory, as well as of practice and research projects where service users have been very actively involved, but also which are being carried out by people with experience as service users themselves, combining their lived experience with the expertise you get from becoming a researcher. So I really stress that.
Great, thank you. Our question at the back. Where's our microphone? Oh, you've gone to, sorry, I had somebody different. That's fine, we'll go here in the middle.
You talked about using outreaching ways of engagement rather than surveys and questionnaires. I wondered if you had any examples of what some of
Yes,
those might be.
a lot of involvement, and my professional life's been very much concerned with involvement. It's about asking people to come to something. And what seems to work an awful lot better is what people have called historically community development approaches, where you go out to try and make contact with people. And of course, as you'll have realised, a lot of what I've talked about are exclusions of communities, particular groups. And so it's really important in a sensitive way, in a way that is inclusive of those communities and how you're trying to do it, so that, for example, one of the projects we supported was a group of women with alcohol problems, but they engaged with other women that hadn't been engaged who had alcohol problems. They found, for example, that going somewhere was a really bad idea. Women were frightened that someone would see them. So a telephone support, means of making input through telephone was worked out. So go and reach out to people, reach out to their communities, and reach out to community leaders. But one of the things we learnt was don't stop at community leaders, because sometimes community leaders reflect all the exclusions and discriminations that we expect more generally. So go out, don't wait for them.
Great, thank you for that. Thank you for that question, Sarah. I think the next one we had was at the back there. Is it the gentleman in the red striped shirt? Did you have a question? I think you were first up, and then we'll probably take two more from further down.
Thank you for that fascinating insight into lay representation. I've worked with some professors who are very keen that all education and training committees should have a trainee present on them. By the same rationale, every patient care or decision-making facility should potentially have a patient present there. But how do you avoid the challenge of the so-called professional patient, or the very loud patient, the squeaky wheel that gets most of the audience, so to speak?
See, I think that's a really sensible issue, although it's often used as a cloak for let's get rid of those people who really know the ropes and will say things we don't want to hear. But it's an important question all the same. And in the organisation I'm part of, Shaping Our Lives, and we've been going for about 18 years, we've had to grapple with that because we do not want, and it's very easy to become, a clique. A group of people who know each other, you get to like each other, and then you don't let people in. And we have been very determined in how we've sort of developed our process, which is explicit, to be inclusive, to offer opportunities for new people to come in, which is what we constantly do, but also in who we get to make sure we get people who have a part of a helpful skill mix for the overall group and reflecting issues around diversity so that we don't become monocultural or whatever the rest is, and helping people gain skills. And that's what it's about. I think for people, you will have some people who do it a lot, and you need those people. The problem is not them. The problem is not going beyond them. Jane Campbell, who's in the House of Lords now, a disabled woman who was long an activist, she said when people said, well, you're not representative, she said, well, if you're going to ask someone to address questions of state and policy issues, you're not going to go and grab the first person on the street. But it is important to be reaching out and including more people, and I think you have to do it. And as a user-led organisation, we've managed to build up trust, because that's one of the big things you have to do if people are going to want to come on board. And little by little, I mean, if I was on, going back to your question, if you hadn't said research, I would have said, what's key? Take small steps and regard small steps as actually very big ones and build up trust. And you won't always get it right, but people are very forgiving and understand as long as you mean what you say, even if you say it the wrong way round. But if they can have a sense of developing trust, it will grow. So it's about growing. And I think if you have a commitment to support diversity, I would say, by the way, never have one person on any committee. We have sought to involve on our our board someone with learning difficulties. But what we ended up doing was involving 2 people with learning difficulties who could be some support to each other, plus a skilled supporter who would be able to prepare them for meetings and support them between meetings, so that it wasn't just that their bums were on the seat, but they were there. And how we worked, we tried to make it as accessible as possible, not using jargon and keeping things straightforward and simple. And what we discovered was that making it so that it was more understandable for anybody made it more understandable and better for all of us. And somehow, although we work like that, we seem to get the business done. And when you go into meetings, and I've been into meetings like that, including meetings related to Imperial, where you don't know what any of the initials stand for, and it takes you some serious time as a professional to catch up, you know that can't be the right way to do it.
Great, thank you. Right, I'm only going to have time for 2 more questions, I'm afraid. I think you were next in line, and then I'll take the one over here. Could you bring the microphone down a little way? Thank you. And I'm sorry for everyone else who's got questions and comments. You might have to address them over coffee, if that's okay. The lady here. Right,
thank you. Just 3 key themes that I wanted to pick up very quickly. One was on the outreach program. I just want to share, 28 odd years ago, which is a very long time, I actually worked on a national DOH campaign, which was run by Kenneth Clark, who was Minister of Health then. And it was a very central program. We were trying to address the very high levels of high perinatal mortality rate within the Asian community. And it was an interesting program in that it went out to all the inner city hospitals up and down the country, looking at maternity care. We took on 200 ordinary lay bi multilingual women, trained them, placed them as link workers between health visitors and midwives and the patients. We looked at the literature around anti and postnatal care, got translations. We did a lot of community outreach development work, getting empowerment and involvement, looking at access and appropriacy of services. And one can go on, and the whole thing was evaluated by Leicester University. So there we are, a really good example of what can be done if there is political priority. But these were pre-Equal Op days. The second point I wanted to make was I was appointed advisor at King's College Hospital, again, sort of 27 odd years ago. We developed an equality policy which moved equality issues, taking all the domains you mentioned, from the margins to the centre. And it was incredible. I was there for 4 years. We looked at employment, training, service, and research. So it can be done. There are lots and lots of good models, checklists, making information available, linking theory and practice.
Can I
and just
ask
lastly,
we need to.
Okay. Just lastly, I'm actually an independent lay chair at the Health Education England. What is very encouraging is how medical education is actually embracing a lot of this now through reflective learning, looking at communications, teamwork, and multi-source feedback. Sorry.
Thank you.
Thank you.
And I think we had one more question over here, just along the row, and I'm afraid that will need to be the last one. Judging by the number of hands up, we could be here all day.
There's so much engagement. Thank you, Peter.
Absolutely.
I've
Very
met
exciting.
Professor Beresford before at Brunel, and one of the OT lecturers who wanted to do a PhD in social exclusion in mental illness with service users led me on after my last hospital appearance. And being involved in my lived experience of psychosis, for instance, and having another group all having their own expert opinion. It's a word in court now that is devalued, but I mean expert in the sense that rather than the doctor, they're the ones taking the pills, they're the ones with the experience of the illness, and they, because of this user-led research, a lot has been developed. And the myth that you can't recover from mental illness is being whittled away. There's still a lot of prejudice, but there's work going on. More is needed, but it's gratifying to feel the effect of that.
Thank you so much. This has been a really stimulating and thought-provoking session. I've learned so much, and I must thank Josephine Ocklew for recommending you, because she said, this is the man you must get, this is the man we got, and can we thank him for coming and enlightening us. Thank you.